Hi everyone, this is Ahmed Alwaidh. Today's webinar will be about three-dimensional obturation. Please, if you have any question, write in the comments, and I'll be more than happy to answer your questions at the end of the webinar. Hi everyone, this is Dr. Ahmed Alwaidh, and today we have a new episode of the webinars, and we will talk about three-dimensional obturation. So I'm Ahmed Alwaidh. I finished my BDS from University of Baghdad in 2008. Then I have completed my MSc in Endodontics from King's College London, UK. I'm a gold member in style Italiano Endodontics, and I'm practicing in both Dubai and Iraq. So according to the quality guidelines been published by the European Society of Endodontology in 2006, they identified endodontology that is that a branch that concerned to anything related to the dental pulp and periapical tissue. And the main disease we are dealing with is apical periodontitis, which is mainly caused by infection. So what is the goal of endodontic treatment? Our aim or goal of endodontic treatment is to cure or prevent apical periodontitis. This is our main goal. And what are the steps required to reach that goal? We have two main steps, which is first, we need to eliminate the cause of apical periodontitis, which is infection. And then we need to seal the root canal system with a hermetic seal or three-dimensional restoration or filling to prevent reinfection of the root canal system. And this is required that we are working in two steps. First step, we need to remove any vital tissue, any necrotic tissue, any bacteria, their toxins, biofilms from the root canal system through chemomechanical debridement. This is the first step. And the second step, then we need to seal that three-dimensional system with hermetic root filling material to prevent reinfection. You may think that root canal system is only canals that we see by X-ray, but in fact, no, it's a very complex three-dimensional system. Before the main obturation system or filling, the main obturation technique or filling was through quadrilateral compaction, where we insert our master cone, then we insert accessory cones by pluggers and spreaders until 1965, where Herbert Schilder introduced the term of three-dimensional filling of the root canal system. That was in 1965, and unfortunately, up to now, there are many colleagues, they are arguing about single cone obturation, and there is no 3D obturation. So this is one of the most interesting papers being published by Herbert Schilder, because if you read it, you may think from where he got this terminology, three-dimension obturation, in 1965. And according to his paper, he said that we all know that bacteria exist in the root canal system. We all know that the root canal system is a very complex three-dimension system. And we are dealing, and he was comparing with the restoration, that we're paying more attention for restoration from coronal leakage, and maybe there is bacteria, but we are not giving the same attention to root canal system. Why? Because we don't see. He described this, that we are just like working in a black hole. And also, he described that all successful root canal system, root canal treatment being done with quadrilateral compaction was made by luck. That's how he described in this paper. So he was the first who introduced the truly three-dimensional obturation of the root canal system, and wall vertical compaction is the name of his technique, and so far we name it Schilder obturation or Schilder technique. And then later, years later, we had Buchanan. He made a modification in Schilder technique. He made continuous wave of condensation, where he introduced first system B, whereas there is a heat source that can give continuous heat while compaction. No need to waves. There was no need of waves of heat, like we need to heat the plugger and put inside or spreader. No, now we have an electric source of heat that can provide continuous heat while we are compacting our 𝗧𝗵𝗿𝗁 at one shot to the apical third. So that was in 1987. And so far, what we are using is based on Buchanan technique or system B. There has been many brands and many companies introduced their systems, and one of them is Fanta, introduced a very nice obturation system that consists of two devices. And by the way, all continuous wave of condensation consists of two devices. We need the first device, which is the heat source that can compact our 𝗧𝗵𝗿𝗁 to the apical third. Then we need another device to backfill our root canal system with a thermoplasticized or heated 𝗧𝗵𝗿𝗁. So we have the 𝗧𝗵𝗿𝗄 and 𝗧𝗵𝗿 by Fanta. What are these characteristics or properties of these devices? Let's go for the 𝗧𝗵𝗿𝗄. It has working continuous. It can give continuous heat for 10 seconds, very lifelong battery, and very high. It can reach to 200 degree in only 2 seconds. And that's what we need. We need very fast heating and very fast cooling while our compacting. The tip is convenient that we can rotate it at our convenience. It has a front light for those who are not using microscope, so it can give additional illumination, which is very beneficial. And also it has an optional wireless control, which I really like. This is the 𝗧𝗵𝗿𝗄 by Fanta. This is how it comes, and also with the wireless control. So it has different options for temperature you want, and different tips, sizes, according to the root canal you're working with, and in which each canal you need to check the tip before obturating. Okay, and this is the light, and also this is the wireless foot pedal that you can activate the heat without busy with your finger. You can use your foot, which is very, very nice, and which I really like. Before obturation, also we need to check. So first we need to check the tip size of the 𝗧𝗵𝗿𝗄, and also we need to check the size of the plugger. And also Fanta offers a variety of sizes, and they are all ISO color coded. We have the green, 35 and 70, and also we have the black, which is 40 and 80. We have also the gold, which is 50 and 100. And there is the blue one, 60 and 120. And also there is the red one, which is 25 and 55. So we need to check the tip size before obturation. However, the plugger should arrive to the apical 5 mm freely in the canal without touching the canal walls. So then we can compact our 𝗧𝗵𝗿𝗄. So basically, we need to check. These are the tip sizes of the pluggers that I need to check, because we need to first, we're gonna obturate the apical third, then the middle third, and then the coronal third. So how we're gonna do the obturation? We put, after we checked our master confit, okay, we introduce with the sealer, then we compact in one shot by 𝗧𝗵𝗿𝗄, which is just like, it's based on a system B concept, okay? So it's in one shot, we compact our 𝗧𝗵𝗿𝗄 to the apical 5 mm. So the stopper on the 𝗧𝗵𝗿𝗄 should be on the 5 mm less than working length. Then we compact until we reach to that point. Then we remove the heater. We deactivate, remove the heat, but the device or the tip is still there. We deactivate the device so the 𝗧𝗵𝗿𝗄 can cool down. And while it cools down, it shrinks. And that's why we are having continuous pressure. Okay. Then after it cools down, we press the heat for 1 second and we move the tip to isolate or separate the compacted portion of the 𝗬𝗏𝗃 and the uncompacted portion, so it can easily removed, just like in this diagram. Then we bring our plugger and then compact again the apical third. So now we have a 3-dimension obturated of the apical third, which is the most important part of the root canal system. Why? Because majority of anastomosis, lateral canals, fins, it's there. The more complexities are in the apical third, and this is what is important. Then we use the other device, which is E-filler, to backfill our canal, the remaining of the canal. So the E-filler, it's just like a gun. Also, it has longer standby time, a longer battery lifetime, and very good grip, very ergonomic design, and it has variety of temperature from 100 to up to 230. And also you have 2 types of tip sizes according to the width of the canal or the size of your canal. And the good thing, which is very important, it can be heated to full degree in only 14 seconds. And this is the difference between the brands. Again, there are many brands, but some of them can reach to the high temperature in 30 seconds, which is too long if you want to obturate. But this one, 14 seconds, which is considerably fast. How we're going to use it? It's also very easy to use. So this is the device, and we have only one button. Long press the button. It's for activating, on and off. Now we put the tip, okay, and there is the key. We can fasten the tip to prevent any excess of melted 𝗬𝗏𝗃, and we put this cap because this portion of the device is hot. So this is to give protection. Then we adjust the tip by the key, not by hand, because it may fracture. And then we can load the gun with the GB bars, 𝗬𝗏𝗃 bars, which is a different type of 𝗬𝗏𝗃, easily melted. Now the device ready. Now again, we have only one button. So long press on, long press off, and we press it to change the temperature. I usually like to work with high temperature in 230. And then we press the gun and we have the melted 𝗬𝗏𝗃 exerted easily from the device. Very nice tip. It can go deeper into the canal. Now, how are we going to use this one? Again, we will finish the obturation. We're going to put the device, the tip. The tip should be reached to the level where we start. And we don't exert 𝗬𝗏𝗃. Why? Because the tip is hot. We need to heat that portion of 𝗬𝗏𝗃. So when we put the 𝗬𝗏𝗃, it can be one piece, not separated. Then we eject the 𝗬𝗏𝗃 for a few millimeters, then take out the gun and we put plugger, and then we condense. It is better to do portion by portion to prevent high shrinkage. And then this is the middle part, and then we will go to the also coronal part. This is the same until we finish the canal. So this is demonstration of how we're gonna obturate a canal with continuous wave of condensation. Sorry. First, we check the tip size. It should go 5 millimeters from the working length of the heater. Then we check the tips of our pluggers. This is the amount of sealer we need in continuous wave compaction, only small amount. And if you can see, it's all the canal been with the sealer. No need for Lontello and put a lot of sealer. No. Then this is the down packing of 𝗬𝗶𝗺𝗀. Then we bring our cold plugger to compact the 𝗬𝗶𝗺𝗀. Now we have the apical third, which is 3-dimension obturated. Then we insert the E-filler. Also, we need to put a small amount of the sealer on the tip. Now, this is the middle third. And then we will do the coronal third. Most importantly, we compact until the 𝗬𝗶𝗺𝗀 cools down to prevent the shrinkage. Now, we have complete 3-dimensional obturated canal. All the anastomosis, all the complexities of the canal should be obturated. So this is the continuous wave of condensation. Now, is there any difference clinically or in terms of outcomes between the cold lateral and the thermal obturation? So this paper illustrated that, resulted that we have more 𝗬𝗶𝗺𝗀, like when they compare two blocks the same size, one is obturated with a cold lateral technique and one with thermal. They have found that more 𝗬𝗶𝗺𝗀 with thermal, that means more space is being filled with 𝗬𝗶𝗺𝗀. That means that in cold lateral, we have more voids that they were not filled with 𝗬𝗶𝗺𝗀. This is another paper, okay? They examined that after like two blocks, one being obturated with cold lateral and the other one with thermal, they immersed in infected solution. They have found out that more than 50% of the blocks that been obturated with cold lateral technique been fully infected after 19 days, faster than the thermal obturated blocks. Why? Because we have more voids, which is easier to be penetrated by bacteria. And also, they have also found that the distribution of filling material, there's another paper, regardless of the instrumentation, the continuous technique was faster and extruded more sealer. So we need to have more control. Also, again, this is another paper indicate that we have more bacterial penetration, more leakage in cold lateral than thermal obturation. You may ask, now we are dealing with very high temperature. Now we are not dealing with the blocks. We're dealing with teeth or canals inside the bone. How gonna this heat affect the bone? May it cause bone necrosis or not? This paper indicates that if we use the continuous wave technique, when used with controllable device, heat device, okay, we will have only negligible temperature increase in the periodontal ligament. So you should use the e-heater within 3 seconds or 5 seconds, and then let it cool it down. Don't use it continuous for 5 or 10 seconds, because you will have heat transfer and also the pain. The patient will have pain. So you have to use it in controllable heat. This is a nice example. Okay, this is root canal of upper first premolar. You can see with the thermal obturation, we have the isthmus being filled. So now we have a 3-dimensional sealed root canal system. Can we do this with a single cone? No. Can we fill these anastomosis with cold lateral? No. It will be filled by sealer, but we all know sealer is not a filling material. Sealer is just like a bond to bond our filling material, which is 𝗬𝗶𝗺𝗀, to the canal walls. Sealer disintegrates. Sealer shrinks. Sealer preserves. So it's not a filling material. Okay. So this is the beauty of thermal obturation. Another example, we have this lower first molar. After chemomechanical debridement, then we have the obturation, 3-dimension, and you can see in the mesial canal, in the distal canal, we have very nice lateral canal. Why? Because of the thermal obturation. And another example for this is lower 8, lower wisdom. It was abutment for a bridge. and there was no leakage. It was very nice bridge. Okay, so I made the root canal treatment through the crown, and also you can see we have very nice 3D obturation in the mesial system. This is also an upper first molar. You may see in the preoperative radiograph, it's a normal, but after obturation, 3D disinfection, 3D obturation, look at the palatal canal and see all of these lateral canals at the apical portion. Why? Because we are using three-dimensional obturation, which is so far considered the gold standard. But now you may ask that right now is with bioceramics, because majority are using bioceramics. And I'll be honest with you, I'm one of them. I like bioceramics, and most of my cases, the majority of my cases for the last 4 years, I'm using bioceramics. And there is no doubt about what's called bioceramic sealer, which is a false. It's not a true name, because bioceramic is not a sealer, it's a filling material. So it should be called as hydraulic or premixed hydraulic bioceramic cement. It's hydraulic bioceramic cement. It's not a sealer. In the bioceramic, our obturation material is the hydraulic cement or bioceramic cement, not the 𝗧𝗵𝗿𝗀𝗃. The 𝗧𝗵𝗃𝗃 is to be used only as a carrier to distribute the material. And it's very easy technique, very friendly technique. We can check our master cone, or sometimes we use lateral, quadrilateral technique with bioceramic. No need for complication, you may say, like the thermal obturation. If you can see here, it's very easy technique. Okay, we introduce our hydraulic cement, then we distribute it with a K file, and then we will use our master cone or accessory cones to distribute the material. As you can see in this video here, we have lateral canal being filled with the hydraulic cement. Again, it's not a sealer. This is a filling material. So you may say, why I'm using or make it my procedure more complicated? You're true, but this is not for all of the cases, because according to this study, it can be concluded that thermomechanical compaction, if you combine, in this paper, they combined like hydraulic obturation, which is using single cone, and modified hydraulic, which is we are using bioceramic with thermal obturation. And they found out that in oval canals or large canals, okay, you have voids with hydraulic obturation. So it is better to combine both techniques. And as you know, we're not dealing with round canals. It's a three-dimensional, it's complex system. Most of the canals are oval in the cross section, not round. And so this raises another question, but how can we use heat with hydraulic obturation? Because as far as we know, the bioceramic cement needs moisture to set. It's only premix. It's one material. We are not mixing two materials. So it counts on the moisture. So how are we going to use heat in this technique? For that reason, many companies, they introduce modification of their bioceramic cement, which is high flow, like we have the one from FKG, we have one flow, we have new sealer flow. So those cements can be used with thermal also. And this is demonstration. This is, we put our bioceramic cement or hydraulic cement. Then we introduce our cone, 𝗧𝗵𝗿𝗃𝗃 cone. Then we introduce heat safely. But you cannot, it's better not to use in the same technique as you're using for continuous wall compaction. It is better to limit your temperature to 150, no more. Okay, you don't need also to go deeper, just like regular continuous wave condensation. No, like to the apical 5 millimeter to the middle of the canal is more than enough. So you will have, so you can ensure the distribution of the cement. Again, modified hydraulic obturation is not that we introduce the heat to the apical portion. No, it's just like we need to push the cement as much as possible to fill the irregularities, which is impossible when we use single cone with a bioceramic cement. This is an example of lower wisdom tooth. Patient came with pain, and there, before he had swelling, now he had fistula. If you can see in the radiograph, we have big lesion. But again, there is a fistula, we need to trace the fistula. And we trace, yes, it's the source root canal system. But again, this is a two-dimension imaging. And you know, we have proximity to the inferior dental nerve. So it's better to check with cone beam CT. And when I took the cone beam CT, now look at the difference. Now you will see the real size of the lesion. And if you can see, there was no bone around the tooth. But we know the problem was from the necrotic pulp. So let's do root canal system, no need for extraction. Because if you know the cause, if you know how to disinfect and fill well, you will get good results. And yes, this is the side. It was another slide. So this is immediately after obturation, okay? And then 6 months follow-up, we had complete healing. We had complete bone formation. And this technique, in this case, I have used modified hydraulic obturation, where I used high flow bioceramic cement with heat application. This is another case. This is another case. If you can see, this is also lower first molar, also being treated with the modified hydraulic obturation. And if you can see, we had lateral canal. Now the question is what to use, which technique you will use. Does that mean cold lateral is not a successful? No, we cannot say that. The success of any technique depends on your knowledge or how you're gonna practice, how you're gonna perform your disinfection and obturation. Take home notes, okay? Always think that you are dealing with a complex three-dimensional system. You are not dealing with single canal. No, you are dealing with a three-dimensional system. And again, most importantly, there is no obsolete obturation technique that can be used for all cases or for all the canals of the same tooth. So you have to know what you're dealing with, what is the canal, and what is the obturation technique to be used. And thank you very much. And please feel free to ask any question. I'll be more than happy to answer. Yes, I'm good. So thank you very much for watching the webinar. So please, if you have any question, write them. No question so far? Okay. So no question so far? Thank you very much for watching. And also later, if there are any questions, I will check the comments and I will reply in the comments. See you next time. Take care.